Our presenter today is Dr. Carol Ward, a professor of sociology at Brigham Young University. Dr. Ward earned her bachelor's and master's degree in sociology at North Texas State University and her PhD in sociology at the University of Chicago. She taught sociology courses and helped evaluate college programs at Chief Dull Knife College on the Northern Cheyenne Reservation in Montana before joining the sociology department at BYU in 1990, the same year her beloved daughter was born. At the beginning of this year, Dr. Ward was appointed as the editor of the Journal of Rural Sociology. She loves being able to read and learn about research from all over the world as part of this position. Some of her other notable achievements include receiving grants from the National Science Foundation and NASA, which helped fund innovative research projects on Native American reservations. She loves how these funds have given her and her students once-in-a-lifetime opportunities to learn in innovative ways. Throughout her career, Dr. Ward has focused on education and minority issues, specifically on education, health, and food security on Native American reservations. In the early 2010s, she was invited to work on a study researching rural women veterans' access to healthcare in Utah and Montana, along with other professors from BYU sociology and family, home, and social science departments. Dr. Ward and her colleagues used qualitative research methods to learn how rural veterans' access to healthcare is a gendered experience. She believes that it is important to use qualitative research methods to study and understand women's experiences. The findings from this study are still relevant and important to understanding women's experiences. Her presentation today, titled Rural Women Veterans in Utah and the Obstacles They Face in Accessing Quality Healthcare, will address these findings about the problems rural women veterans in Utah face in obtaining healthcare. Please welcome Dr. Carol Ward.
Well, thank you very much for inviting me to do this presentation. I really enjoy talking about this research. I have to say, it's kind of interesting to me and really nice to be back standing up here. I've done lectures here before, but the last one was kind of a bittersweet opportunity. I was asked to do the prayer before the last lecture by Dr. Ralph Brown, my colleague, who later passed away. And So I remember that. It was a wonderful lecture and terrific. He talked about international development and how to study international development. It was really terrific. So thank you for giving me this chance to talk. Let's see. That was a terrific introduction. Thank you very much. Let me just start with a little bit of background information on women veterans. Over the last 20 years, of course, women have joined the military in record numbers. And as a result, the female veteran population has grown as well, so that now we have 10% of all veterans are women. And of course, they also represent an increasing share of the VA or veteran healthcare patients, almost 10% in 2017, compared to males at 7% in 2008. Female veterans' use of VA benefits increased substantially between 2008 and 2017 from 36% to 50%. Interestingly, more women veterans use only VA healthcare. So to bring it back to Utah, in 2021, Utah veterans numbered almost 12,000, 8% of all Utah veterans. And a little more than a fifth are 65 years of age and older. Some additional considerations about, understanding the experiences and situations of women veterans include that women veterans are more likely to live in poverty. About 9.5% of women veterans compared to almost 6.5% of male veterans. And women veterans are twice as likely to use food stamps compared to male veterans. While at least a quarter of women veterans reside in rural areas, they use VA health services at a lower rate than males. And it's important to realize also that a larger percentage of older veterans live in rural areas than other age groups. Okay, so just to summarize briefly what some of the earlier research said about women veterans' experiences, between 2000 and 2010, there are a number of research reports on women veterans' needs because of this increasing number. However, even despite the VA's efforts to better address women veterans' needs, research continues to show persisting obstacles, such as establishing eligibility, the availability and quality of services, transportation to those services, and timely access. So those are a few of the issues that have continued. So for this research, here are our questions. We wanted to know, what are rural women veterans' experiences with accessing healthcare in Utah? How do their experiences change as they age and face new healthcare needs? And what institutional and contextual influences affect their access to and the quality of the services they need? Several relevant perspectives that I want to just mention briefly. Gender and life course perspectives are particularly helpful. These help to highlight veterans' gendered experiences with accessing the VA healthcare. For example, persisting stereotypes about women's abilities and roles, and also the treatment they receive, the attitudes toward women, being in the military, being veterans, and the way and behaviors toward them. Also, the era in which they served in the military and then became veterans is really important. And of course, changes in women's roles in the family, as well as their involvement in the military. So gendered experiences are, really an important part of this research. Life course perspectives also help to clarify the effects of the timing of events that women experience and the transitions through the life course. For example, when they return to civilian life. It's interesting to think about that. When they return as veterans, how were they received? Did people recognize and accept their military experience? Because that hasn't always been the case. And later on in the life course, timing of retirement. Insurance coverage may actually decrease at the same time that their healthcare needs change or increase. So all of these timing issues throughout the life course are important to understand. And of course, individual choices affect women's access to healthcare and their health trajectories. So one choice, for example, is whether women decide to share their veteran status with others. Or do they simply not acknowledge it, perhaps because they don't know how people will respond to that? Do they choose to form social networks with other veterans? And this is an interesting one that I'll talk about more later in relation to the findings. Do they use their experiences in the military and their resources that they've accumulated throughout, and their expertise that they've accumulated throughout their lifetime to advocate for other veterans and access to benefits? Rural contexts, of course, affect if or how veterans access the types of care they need. We have sitting here several colleagues who have worked on projects related to this research. Michael Cope and Scott Sanders and Lance Erickson, they've all been part of looking at veterans' healthcare needs and access in rural contexts. So ask them questions too. Just all right. So in sum, there are all of these different perspectives about gendered experiences in institutions and rural contexts intersect with life course events to create differential access to healthcare. Okay, so where did we do this study and how did we do it? This was a qualitative study design. We wanted to get detailed information about women's experiences. There had been some excellent research prior to this, of course, that was based on survey research, but qualitative work allows you to get up close and personal. The sites for our study were selected from rural Utah communities that included larger representations of women veterans. We wanted to go where it was likely that we could recruit and find women veterans to talk with. The sources for recruitment included local rural service providers that we contacted and asked to help us invite women veterans to participate, veteran support groups, and other organizations. So what we did was we conducted several focus groups in 2011 and 2012. We had 22 women participants in 3 focus groups, 6 to 8 women per group, and they were talkers. Each group lasted a good 2 hours, in some cases much more. What we did was we invited women to join us for a meal. And we had a really nice meal for them, and we came and visited while we ate together. And then following that, we invited them to talk about their experiences. So a little bit about the participants. 60% of the women in the focus groups were veterans. Typically, they were in the Marine Corps, the Army, and the Air Force, but we had a couple of people who were in the Navy and so forth. This next part is interesting. We had women veterans who had served in the military in World War II, as well as Korea and Vietnam. 62% of the participants were ages 60 and over. A third were 85 and older. The oldest was 92. So interesting. Most were retired. About 70% were married or widowed. Almost that percentage had some college, some had degrees, but almost all had some college experience. All had health insurance, and they were typically white and working class and middle class women. So just to give you a brief glimpse at what I'm going to be talking about, here are some themes that we identified in our focus group data. Barriers to women veterans' access to healthcare. They talked especially about establishing eligibility and qualifying for VA services. Problems with the use of VA services, availability and quality, cost, and distance to services. Perceptions of unmet veterans' needs, such as healthcare, but particularly mental health care needs. And then this last part, which I'll spend more time on, women veterans' responses to their situations in rural communities. They expanded their caregiving roles, and they advocated for women veterans and all veterans, actually. Okay, so now for the fun part. I want to start by talking about the eligibility and qualifying for services. A central challenge for the women was how to qualify for VA healthcare. And you would think that that would be something that they would automatically know about, but they didn't. Every single one of them talked about, yeah, we kind of heard a little bit when we left the military, but, we were just anxious to get out. And so we didn't pay that much attention. We thought, well, we'll figure that out later. And for some of them, it was much later. But I love this quote. One of the women just voiced what so many of the other women said. It's kind of like VA in the sky. Who uses it? How do you get into it? Is it a myth, or does it really exist? This indicates they clearly didn't know how to go about doing this. Oops, sorry. The second quote also kind of expresses the same sentiment. Well, it's like a promise that you don't know how to use. They say all veterans are eligible. That is really absolutely not true. So why isn't access to it made easier? And why don't they educate you when you get out that you have that? An excellent question. So that's the first challenge. But for older women veterans in particular, there were 2 central issues. Qualifying for services after having been out of the military for so long. And also, they perceived a very low priority of services to rural areas. So one woman expressed it this way. She said, this thing about the VA, some years issuing authorizations for you to have local care, and other years not. That's a difficult thing to manage. And so what she's referring to here is that the VA has established local health clinics in many communities, but they were getting different messages about where to get the care they needed. Do they go locally? Do they need to go to a VA hospital? What's the situation? It seemed to be changing. And another veteran commented, it seems like it's all budget connected, which means rural communities must be a low priority. They didn't see the resources coming into their communities, and they should be high. It would save the government money. It's cheaper for them to give it to us than it is to ship us there, meaning Salt Lake, all the time. Now, let me mention this. Veterans are eligible for health care, but they're also located in a geographic area. So they, for example, if they need surgery or they need specialized care, there are certain places that they can go and get that care. And for Utah, it's the VA complex in Salt Lake. This is really interesting for the women who lived in southern Utah, because they're all very aware that there's a brand new VA hospital in Nevada, east of Las Vegas. And it would be much easier for them to drive up there and get specialized care or things that they need, but they can't do that. They can't use that facility, so they must go to Salt Lake. Scheduling, availability, and quality of services are also issues, challenges that the women identified. For example, one woman described it this way, but this is the thing about the VA. I have to go for GI. So she's talking about specialized treatment. It's only on Mondays, okay? I have to go to the women's clinic. It's only on Fridays. They're all on different days. So for her, because she lived hours away from Salt Lake, and others mentioned very similar situations, she had to either go up to Salt Lake and come back home and drive that a couple of different times in the same week, or she could go up to Salt Lake and stay from Monday to Friday in order to go to her appointments. So this was problematic. And this is another quote about the women's clinic in Salt Lake. I've been to that women's clinic probably 6 times. They hire a doctor, an old, crusty thing from downtown Salt Lake, comes in one day a month on a Friday. He's a disaster. Most of the women knew exactly who she was talking about. Let me just mention, however, that that's changed. The VA has attempted to provide more physicians and more female healthcare providers for women veterans. So it has been improving, but this comment was pretty interesting. The quality and cost of medical care, as well as travel and distance, as these quotes have begun to suggest, are problematic. So another veteran talked about her experience. She said, I can go to Walmart or Costco and have my eyes checked for $49 or $59. So the VA send me this letter that says you go to Salt Lake and you get your eyes checked. So I drive up there. It requires a night. I have to stay there. So you get 3 meals in a room. So by the time the VA pays my travel, pays my meals and my room, they've paid $300, $400 for something that I could get down here for $49. So again, they're questioning, can we get local care? And I think the VA has responded to that by making more options available, but it's still problematic in some rural communities. But here's the thing that almost every single woman mentioned. The biggest thing of all to me, we're seniors, and there's a heck of a lot of risk in driving 650 miles in unfamiliar territory up there, that busy city. The risk is huge. So for these women veterans, they're experiencing what, people experience in rural communities. When you need specialized care, when you need to get something that you can't get locally, you go where you have to go. The VA is expanding options locally, but women still can't get all the care that they need locally. And so, as Scott's research suggests, bypass behavior is something that many people experience. They bypass local options and go to other healthcare providers. Other significant concerns for rural women, access to prescriptions. In this first quote, a woman talks about her prescription program that she's had, and she lives in a small community. There's a Walgreens, but the Walgreens dropped their contract with this particular prescription program, and they're not open 24 hours anymore. And that was problematic for her and her husband, who is also a veteran, because they needed to access medications after his surgery, and they couldn't get them at the hospital or at the pharmacy. And several women talked about having that happen. Another issue was the VA hospital pharmacy and clinic. Several women talked about how the VA stocks all kinds of medicines, but very little for women. So very few things for women specifically, which meant they had to pay for them in a different location because they couldn't access them at the women's clinic at the VA hospital. Okay, this is, I think, one of the most interesting parts of this research. The invisibility of rural women veterans affects their access to information and healthcare as they age. One retired veteran's comments represent what other women said. I think part of the unfortunate stigma that surrounds VA medical care was just that first step through the door. You kind of have to walk in and they just figure you're somebody's wife because there aren't any women there. The biggest challenge sometimes is being identified for who you are, that you're not attached to somebody. That's not why you're there. So going to VA clinics and VA hospitals was oftentimes seen as kind of intimidating to some women, especially if they were just getting familiar with using these sources of healthcare, and they walk in and, people don't even understand that they're a veteran. The lack of recognition of women veterans has important consequences in a male-dominated institution. It was interesting, though, all the women expressed the importance of their identities as veterans. That's not something that changed over their life course. Sorry for the typo in the first line there. But it was also interesting. They also acknowledged their own difficulty with identifying other women veterans. They didn't necessarily know how to find other women veterans in their communities. And that impeded them forming social networks that could provide information and assistance. So you might be thinking, well, what about the men veterans? Couldn't they go to meetings at the American Legion or some other organization and get help that way? Well, they tried. Women talked about going to those meetings and feeling very unwelcome, and people asking, why are you here? So what did they do? Well, they didn't go back. So there was a situation where they didn't really know very many other women veterans. So one woman described it this way. She said, it strikes me too that if you're a female veteran in particular coming back here, and she's talking about her small rural community, it would be hard to find other women. And I've talked to quite a few people who you would think would know. If you're a woman and you have certain issue, it would be harder in this community to find another female veteran and try to say, I've got this issue. Do you have any experience? So they felt like they were kind of on their own, trying to figure out how to access healthcare, how to navigate the system. These kinds of experiences that the veterans talked about reinforced their perception of the lower status of women veterans. These experiences were not new, however. They began during their military service and ranged from not feeling welcome to being belittled or shamed, and in some cases, physical violence. Every single woman kept up with the reports on women's in the news about women's experiences in the military. Their conclusion was that it had actually gotten worse. Now, we might question that and say, well, there's a lot more in the news about it, but their opinion was that while they their belief was that it had gotten worse for women in the military. So one of the things they talked about was their responses to the treatment that they experienced. They did acknowledge that there were men who were very accepting of women in the military, but there were a lot who were not. And so they had to decide, how do we respond to this? Some ignored harassment, and others responded in different ways, staying away from the men that, they got poor treatment from. Others took more assertive actions. This is one of my favorite stories. This woman said, and this was a woman in her 90s who was in World War II. I pushed a guy off a ship on the Potomac River in Washington, D.C., because he started making advances. And I just gave him a little shove and he went overboard. He swam to shore. I never saw him after that. I'd say that's pretty assertive. So as you can imagine, when she told this story, everybody there said, whoa, wait a minute, we need to hear what happened after that. Well, we need more context. And so she explained that this man had been making advances for some time. And she said he was just being really fresh. I love that. And he came up to her this one day and just was relentless. And so she just thought, I've had enough. And when she pushed him overboard, we all said, well, did you get in trouble? And she said, no. And we thought, well, why? Well, her commanding officer was there and he saw the whole thing. He also knew that she had told this guy to leave her alone and not bother her numerous times before. Well, I was wondering, so why didn't he stop it? But anyway, when that happened and she saw him and she went to him and said, okay. And he said, no, I saw the whole thing. And she did not have any negative consequences from that. So I don't know what happened to him. Apparently he swam to shore, so I guess he made it out okay. So clearly people responded in different ways. So the last part of this that I want to talk about is women veterans' roles in their families and communities. As they continued to be part of the community and begun to establish relationships with new veterans who were coming into their communities, some veterans expanded their caregiver role to provide assistance to other veterans in their family and community who had health and mental health needs. One veteran talked about her family. She was a veteran. Her husband was a veteran. Her husband and her father were both veterans, and she had a son who was a veteran. So there were multiple generations. And when her son came home, he had some very severe PTSD. And she said, it was really up to her. She was the one who learned how to navigate the system to help all the veterans in her family, including herself. And when she talked about helping her son, she said, well, it took about almost 2 years because he would go for an appointment, and she met in Salt Lake, and then he would have to have a follow-up, but they would have to send a letter in the mail to get the appointment. And so the follow-up would be 6 months out. That was very problematic for her family. This young man was really struggling. His medications that they had given him were not working. He wanted to go to work. He couldn't because of the medications he was taking. They wanted him to be in a therapy group. He did not feel comfortable in that group situation. He wanted individual therapy. It took really years for them to work out the kind of treatment that he needed. So when women veterans saw these kinds of things happening for men and women veterans, they decided to step up, and they began to play much larger advocacy roles in their community. The women veterans have become more proactive, advocating for recognition in their community. So when the American Legion guys organized their participation in parades or other local events, the women have to go and say, we want to be part of this too. but also helping other veterans in the community. This includes volunteering to assist with daily needs of veterans in nursing homes or assisted living, as well as contributing to local veteran projects. It was so interesting. The women talked about what kinds of things they did. Now, it's important to realize that these were largely older women who had retired. Not all of them, but some of them had retired. They had time and they had expertise and knowledge. They could figure out what to do. So they let the assisted living and the nursing homes know, if you need someone to help with a veteran, call me. And they did. So women talked about, I get called out of work all the time because they know I'm so close. They say, is it possible that you can come over and hold a veteran's hand? I'm called because the CNAs do not have the time. So even the people working there couldn't always be with the veterans when they needed someone. It was really interesting. They described a particular event, Air Force event, where there were planes flying over. And some of the Vietnam veterans were really upset by that. And they started crying. And the female veterans went over there to hold their hands and just be with them while they experienced these episodes. So just a few concluding remarks. The analysis of our data, I think, indicates several key elements. Gender stereotypes, invisibility, and discriminatory treatment have persisted well beyond many of the women's military service. They continue to have challenges in relation to accessing healthcare in rural locations, although there have been improvements for sure. There are still some challenges for these women. Women developed new needs as they aged, and they had to learn how to navigate the healthcare system in order to meet their needs, but also the needs of other veterans. Their identities remained important throughout their life. And women advocated for their own healthcare, and they expanded their caregiving roles. Most of the women that were in these focus groups had children, and they were married, they had kids, they had extended families. And so caregiving in their minds now was expanded to include veterans who were outside their family, that were local community residents. When we asked them what would be necessary to create more effective health care, they suggested improvements in accessing the VA services, the distance and time demands in particular, case management to provide for continuity of care. They found that their providers were always changing. Increasing mental health services. This was particularly important to women who were getting to know the veterans, the younger veterans who were needing help with PTSD and other issues. You might be wondering, okay, so we collected these data a while back. Are these findings still relevant? And it turns out they are. In fact, a recent report in 2018 and others that I've seen since then indicate that many of these issues have persisted. Information about eligibility, especially for older women veterans who, they've just been out of the military for a long time. And many of them, although this is changing, they didn't want to get on the internet and try to search, So this is where younger veterans, I think, had some advantages because they were not intimidated by going onto the internet and looking for information they needed. But the availability and quality of services at the nearest VA hospital or clinic continue to be challenges. Transportation, female healthcare providers, mental health services, these continue to be challenges for women veterans, and a consistent access to the full range of gender-specific benefits and services continues to be issues for women veterans. And then, of course, access by rural veterans, especially older rural women veterans. Okay, all right, that's it. Thank you.
Dr. Ward's presentation on veterans in rural Utah and the obstacles they face in accessing quality healthcare gives important insight to the struggles women veterans, as well as women in general, face when it comes to accessing quality healthcare. Barriers to healthcare, such as eligibility and qualification for VA services, the scheduling and availability of services, the cost of care, distance from VA clinics, access to prescription medication specifically for women, lack of recognition for female veterans, and the gender hierarchy of veteran status all play a role in women veterans' access to quality VA services. Understanding the gendered experience of veterans, especially for a group of women that is representative of women veterans generally, shows the kinds of stereotypes that women have faced in the military due to their gender, whether they be based on ability they are presumed to have, what types of tasks they are assigned to do, among many other things. These stereotypes have overreaching impacts that eventually affect one of the most important institutions for a person's well-being, their healthcare. When we think of VA care, who do we picture as users of the services? Who do we picture when we think of veterans living in poverty or experiencing homelessness? Who do physicians, healthcare practitioners, and government leaders shape policy around and expect to be users of these services? For many of us, depictions of male veterans will probably flood our minds when these types of questions are asked. It is, of course, important to consider the inequality all veterans face when looking at issues of healthcare and poverty, but inequality specifically relating to women isn't talked about nearly as much. This contributes to the invisibility of female veterans, as Dr. Ward mentioned, that can have dire consequences when it comes to accessing quality healthcare for women. More broadly, Dr. Ward's research shows trends that can be generalized to help explain disparities we see in healthcare between men and women. The issue of access to quality healthcare is one that garners the attention of researchers throughout the world and is especially important to the field of global women's studies. Whether it be rates of maternal mortality, accurate diagnoses for health issues unique to women, or the lack of research on how certain medical therapies impact women specifically, it is obvious that an extremely androcentric healthcare system exists both in the United States and globally that is unfit to handle issues unique to women. Many of the same issues brought up by Dr. Ward can be looked at in the context of healthcare disparities by gender in general. When female veterans are given different opportunities to access healthcare than men are, we are inadvertently showing them that they don't matter as much. When a female veteran is asked, "Why are you here?" because she is not accompanied by a man to a VA clinic or other community of veterans, it shows a lack of acknowledgement and respect for the sacrifice she has made. The research Dr. Ward presented today is crucial to the lives and well-being of women veterans as well as women generally, as we fight for a better and more equitable healthcare system that serves women just as well as it serves men. Thank you so much, Dr. Ward, for your presentation today. And we will now move to the Q&A portion with the first question from Abby King.
Sorry. Okay, thank you so much, Deegan, for that wonderful response, and Dr. Ward for your informative presentation. And so if you have a question, we'll have you socially distance line up at the side of the room up for the microphone. And then we just ask that you state your name, minor, and major before you ask your question. And then if you have a question on Zoom, Lindy will ask those for you, and we'll just kind of alternate between you in person and Zoom. And so the first question I'll ask for Dr. Ward is that you noted in your presentation that many women veterans have taken on caregiver and advocacy roles. And so although we're just still students, many of us are pursuing careers in healthcare and public health, including myself. And so how can we advocate for rural women veterans now and then in our subsequent careers?
That's such a great question, and I wish I had a really great answer. I think, in communities, finding where the women veterans are, and that's not always easy. It's so interesting. I was thinking as you said that, the women veterans talked about being able to easily identify the male veterans. They said they wear their caps from the branch of the military that they served in. Women don't wear caps. And they're like, so we don't know who each other. When we invited these women to come to our focus groups, it was just fascinating. The conversations that we heard as they arrived and they met each other, they said, I've been hearing about you and I've so wanted to meet you. There wasn't a social context or a point where they felt that they could meet each other. Maybe they ran into each other at the clinic, but that would be, pretty chancy. So I think finding places where women veterans may be, so it's going to vary by community. but, being able to get to know some of their needs and provide some assistance to women, I think would be terrific. So it varies so much by community. I don't know, Michael, Scott, Lance, do you have ideas? They're shaking their heads no. Okay, so there you go. I think being creative is important. It was easy for us actually to get in touch with women veterans, to invite them, because the local care providers knew the women. And so they extended invitations to the women. And so local care providers could be a place to start. Yeah, Scott.
So my dad was a vet. They have greeters there that are public volunteers, because especially at the Salt Lake campus. So
yeah,
there was people there that would just go, like coordinate all sorts of things. So there's Salt Lake one. There's always going to be options for experience and service there. And then there's a new C-Box community one up in Orem that just opened a new VA thing there. And I'm sure same kind of capacity. There's going to be a need for just people to be there, because veterans come in lots of different household structures, right? Some of them are on their own. Some of them have people to take them there. And so there's always, especially now with students, that's a great way to get involved in, to be able to see the systems and then identify other opportunities for volunteering.
Oh, that's such a great, the local clinics that the VA is attempting to set up in more communities, I think is a great place to start. Yeah. Just finding where they are and getting familiar with them and offering to help. Yeah, it'd be great. Okay. Any other questions?
Sociology and global. And at the beginning of the presentation, you mentioned that female veterans were more likely to be in poverty. And I was wondering if you know why that is, and if that relates at all to your presentation on VA healthcare services.
Well, the circumstances of women veterans vary tremendously. And, I think in Utah, the women that we talked with were mostly middle class, but also working class. And I think their education, for example, affected very much the kinds of opportunities they had. But I think where women have less education and less opportunities for employment, they can be in situations where they are close to the poverty line or below the poverty line, especially also if they have children, and they may be single parents. We had single parents in this group, and they talked about their struggles. But, the focus of this presentation was largely on the older women veterans, but the younger women veterans did talk about that quite a bit. The opportunities that were scarce in the communities that they lived in, and how that made their quality of life, much more challenging to support. So that's, I think, in part. Another part of this research that I did not talk about today was about the experience of Native American women veterans who are younger. And from the focus groups we did with them up in Montana and in 2 different reservation contexts, they spoke about that quite a bit. The opportunities in reservation communities are scarce. And so they had to choose between staying close to their home community or moving to a city where they might have better opportunities. But they also needed to go to school and get the education credentials to be able to access those opportunities. So there were some tough choices for these young women who, many of them had children as well. And so moving away from their home community where they had family to help care for their children was a challenge, because they could go away and go to school, but then they didn't have that family support that they needed. So these were some pretty significant challenges for these Native American women veterans. And I think that's true for other women of other groups as well. Does that help?
Yeah.
Okay, thanks.
There's a question from the chat from Tristan. And it says that, what can we do to ease the burden of female veterans in our state?
Okay. Well, I think, locally, I think that recognition of women veterans, that's where it starts. Recognizing that there are women veterans of all ages in the community is, and being able to identify what their needs are. What kinds of help do they need? What kinds of things will be meaningful to them is a place to start. And then, communities do have resources. And to the extent that those resources can be utilized and directed toward women veterans, I think would be, some ways to start thinking about that. Veterans have different needs. For some, as Scott was saying, for some it's transportation, for others it's information. But I think it starts with making them more visible in the community. And that's not an easy thing to do. But my guess is if people reached out to women veterans, they would respond. They certainly did not hesitate to respond to our invitation to talk about their experiences. They wanted to talk about their experience because it helped address that invisibility that they had been feeling. So I don't know, is that helpful? Okay.
My name's Rebecca. I'm a public health major and global women's studies minor. And at the beginning of your presentation, you mentioned that one obstacle that women veterans face is that they served in a different era of military involvement than the men. Could you expand a little on what that means? And
well, women's involvement in the military happened in different ways in different eras. So they did certain things in World War II. They did other things in relation to the Korean War, the Vietnam War, and their involvement has expanded over time. He wants to ask a question. So I think, it's important to understand when the women served in the military and what kinds of roles they had or permitted to have and how those have changed over time. So when I talked to the younger veterans, they talked about being in the field in combat, in relation to combat. Now, they had different kinds of duties, but they were there in the combat areas. And the World War II women veterans didn't talk about that so much. Some of the Korean veterans talked about that. But more recently, their roles have expanded and have been very demanding physically, as well as mentally, psychologically. And so I think understanding that actually helps give us a better sense of the range of needs that women veterans may have when they come back and make that transition back into civilian life, which is not easy. It's not easy for any of the veterans. But, depending on what their experiences have been, that transition is going to be maybe a little bit more challenging, depending on what they did and what they experienced. Is that helpful?
thank you.
I'm Riley, and I'm a psychology major in global women's studies and family life minor. And you mentioned that more women in healthcare roles would improve conditions for women. Have you noticed that this has been improving? What has that change been like? Yeah,
it varies by region and area, but women veterans have told me that where they used not to be able to access female healthcare providers, now they can. So I think that's an improvement that the VA has been working on. It's not everywhere because it's still a challenge in rural communities. I mean, if you think about healthcare in rural communities, who's leaving? The doctors, and if there are women PAs, for example, are nurses, then, they can access people that way. But healthcare in rural areas is challenging, and so if they want to go locally to a clinic, they may or may not have access to female healthcare providers. If they go to larger cities, they probably have a better chance, but it's still, it still varies quite a bit. Scott, do you want to add anything to that?
That's a big issue, just matching, even see with this is matching
efficiencies, right? Like you have a specialized clinic for one person in a community.
Yeah.
That's the heartbreak of all this tension is between everyone wants to provide care, but where are you driving that line on efficiency? It seems pretty heartless. At the end of the day, that's part of all these decisions in communities. There's a growing tension and local perception on healthcare. It's really complex and it's not And like Carol was able to show, it's unique in each setting and each person. So there isn't a universal, here's the answer to solve everything, because it's going to vary on town to town, person to person.
So for women veterans, like for other rural community residents, if they need specialized care and you're a woman, then you probably have to go to the closest city and to, healthcare providers there in order to get the kinds of care you need. It's a challenge for most rural communities, but especially rural women veterans.
Question from the chat, and it's from Joshua, and he is asking, how would you change the study if you were to do a similar study on female veterans in the future?
Wow. More locations. I would love to know if the experiences that we learned from talking to women in Utah, how they compare to women in other contexts. I mentioned the research we did in Montana. They were tended to be younger women veterans, and they were Native American. They said many of the same things, but they also had some unique challenges. So I would expand that and go to other communities, other minority communities, and so forth, so we can get a better sense of how these findings, compare to women's experiences in other places. It's Lance.
Hey, I'm Lance Erickson. I'm a sociology professor. At the very beginning, you said that women who use the VA are more likely than men who use the VA to use the VA full time for all of their health care.
Mm-hmm.
In the context of your talk, that sounds like makes me feel really sad in some ways, because it's so difficult for them to get access, to get there. The services aren't there to provide them in many ways what they need.
Yeah.
Do you have a sense for why so many of them are using it exclusively? It seems like it's an extreme burden. Is it lack of other access to healthcare?
I think so.
Force
Yeah.
disadvantages.
I think it's that. I think it's lack of access to other sources, but it also could be that they have found the combination of care that they need in a particular place. So they kind of luck out, and the range of services that they need, they can actually get through the VA, and they like it. The most recent research has shown when women veterans are asked, do you like the care that you're getting from the VA services? And they say, a lot of them, the majority say yes. That's different than it was 10 years ago. So it has improved. And I think when women, kind of luck out and have that combination of resources that help them personally, then they're willing to use the VA care. And especially, if they live close enough to an urban area where they can get the care they need, as well as the local clinic support that they need for routine care, for example, that may be a good situation for some women. But yeah, it kind of made me sad too. I thought, geez. Okay, thanks, Lance.
Okay, so unfortunately, this is not a question, but we are run out of time. So we'll close the Q&A session right now. But if you have any other questions, you're more than welcome to stay after and ask Dr. Ward. But I wanted to give a final round of applause for her wonderful presentation.
Thank you. Thank you very much.